Welcome, everyone. I'm Dick Deming, Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And you are in for a treat today, and so am I, because we have two guests, two medical oncologists from the University of Iowa. And they are joining us right now. We have Dr. Nicole Fleege and Dr. Sneha Phardke. Welcome.
Hi, thank you so
having
much.
And before we get into our topic, and we're going to be talking about sexual health in cancer survivorship, let's get to know our guests a bit. So I'll start with you, Nicole. So I have to admit, I don't know a lot about your background. So I grew up in South Dakota. Where did you grow up?
I was born in Chicago and spent a few years there, but then would claim Dubuque, Iowa as my hometown.
Oh, all right.
I
So
am in Iowa.
in
Yes,
high school
was in Dubuque. I just actually gave a presentation at my high school about cancer research.
Oh, nice. So when you graduated from high school, how many in your graduating class?
We had around 150.
Okay. So my favorite question is, what was your personal claim to fame in high school?
Oh gosh.
Don't be bashful.
I know. I'm thinking I was really good at mock trial, maybe something related to that. Yes.
So did you do debate and speech?
Yeah, specifically mock trial. It started, I didn't do debate or speech actually, but it was the only extracurricular I was good at because I had no athletic ability. And so I got to just argue my points, and I feel like that has served me well over the years.
Yes. How about music or theater?
I did not do either of those. I was a lot of extra science classes. And then I did try to play every sport and ultimately was relegated to manager, but I was a manager for a lot of the sports teams. Very good at cheering for others.
And then when you graduated from high school, what was your next step?
I got my undergraduate degree at the University of Iowa. So I tell everyone I'm almost a lifer at the University of Iowa. I got a bachelor's of science. My degree was in exercise physiology.
Oh, okay. Did you know as you started college that you wanted to go to medical school?
I thought I did. When I was a senior in high school, my dad passed away from lung cancer. And so the beginning of college, I went a little bit back and forth on if that was really the right choice for me, just knowing that experience. But ultimately, through doing volunteer experiences, I realized I wanted to stick close to patient care, be that person for someone else going through something hard. And so I think by sophomore year, I was pretty set on medicine.
You know, my mom was diagnosed with stage 4 lung cancer when I was a junior in high school. And I'm sure that as I look back on it, that her invisible hand was kind of maybe every time I came to a fork in the road might have been tipping me in one direction. And then from medical school at the University of Iowa, where did you go?
I went to the University of Iowa, Carver College of Medicine. I stayed here. I was lucky to get a scholarship, and we had connections here, and so really enjoyed my medical school here, and then stayed for residency as well.
Okay, and so residency in internal medicine,
yep.
And then fellowship.
I did a chief resident year before fellowship, but then I finally left. I went to enemy territory and went to the University of Michigan for fellowship.
Okay, and then came back. Obviously,
yes. After 3 years, we came back to Iowa because I knew Dr. Phardke. She was my mentor, and so I knew I had to come back and continue working with her.
Well, great. Well, that's a great segue. So we'll next talk to Dr. Sneha Phardke, also a faculty medical oncology at the University of Iowa. So Sneha, where did you go to high school?
I grew up in a suburb of Kansas City called Olathe. So I went to Olathe East High School, and I grew up in the Kansas City area from when I was 8 years old.
And how many in your graduating class in high school?
Gosh. Over 400. I want to say 450
big.
or so. Yeah,
okay.
It's a big high school.
So what was your personal claim to fame in high school?
Well, if I had to actually think of one, I think I was in the top 3 in my graduating class. It got a little competitive toward the end because it was like a race of how many AP classes you could take to get your GPA up to the highest. But I think we were pretty close.
Okay.
Those like 3 to 5
So
of
I'm going to
us were
say
pretty
you were
close.
co-valedictorian.
Yeah, sure.
Yeah,
Yeah, there you go.
good. And what about extracurricular activities in high school?
Yeah, so I was in the band. I played the trombone in band all the way through high school. I played soccer all the way through, I think, sophomore year. Um, and I think that was probably mostly what I did. And then, like Nicole, I took lots of science classes and, National Honor Society and all those things that you
Yeah.
do in high school.
So your favorite song to play in the band with your trombone
Louie
in high
Louie.
school? Okay.
No, I don't know. But I just like that one because I can still play it. If I got my
Yeah,
trombone
okay.
out, I probably could still
Good,
play it.
good. And then from high school, where did you go?
I went to the University of Missouri in Columbia, and I got
And
my bachelor's in biology.
did you know going to college that you had becoming a doctor as your plan?
No, I actually started out as a dietetics major, so I was going to be a registered dietitian, but pretty quickly changed. I think in my freshman year, I realized that was probably not going to be as fulfilling to me as being a doctor. And like Nicole, I also had done some volunteer opportunities and really felt like probably going to medical school was the right path.
And then for you, medical school was where?
I went back to Kansas City. So I went to the Kansas City University of Medicine for medical school. And then I stayed in Kansas City at the University of Kansas for my internal medicine residency.
And then from internal medicine on to fellowship.
Yep, and that's how I ended up in Iowa. So I came to the University of
Okay.
Iowa for my hematology oncology fellowship, and then I stayed on as faculty.
Okay. Well, wonderful. Well, it's great to have both of you on. I feel like it's an abundance of riches to have both of you. And maybe and start with you, Sneha. Maybe describe what you do at the University of Iowa. So here in many community cancer centers, there's not a subspecialization, and most medical oncologists kind of do everything and see every patient. But at the university, where you have lots of medical oncologists, there's often subspecialization. So maybe describe what you have done and what your current role there is at the university.
Yeah. So I'm a medical oncologist, but I specialize in breast cancer. So basically my clinic patients, I have 2 full days of clinic, and they're all patients who have breast cancer, which is, like you said, typical at the University of Iowa. Most of us subspecialize so that we really only see 1, maybe, 2 cancer types. And as a faculty member at the university, part of my time is also spent doing research, teaching. So I teach medical students, residents, and fellows. And then I have some other roles, kind of administrative roles. So for example, I am the clinical director of our cancer survivorship program here. So that also, I spend a chunk of my time each week working on expanding and improving our survivorship program.
Great. And Dr. Fleege, maybe give us a thumbnail of what your current role is at the university.
Yeah, so similar to Sneha, I have some clinical time. I'm a little bit different that I have more dedicated time to research. So I have 1 full day of clinic. I spend half of that time, a half day at the University of Iowa seeing patients exclusively with breast cancer. And then I recently started spending a half day in clinic at the local VA here in Iowa City, treating veterans with all cancer types. The remainder of my time is spread across teaching, research, and administrative goals, but I would say is more heavily focused on research right now.
Okay. Well, tell us a bit about your research.
My research, if I had to describe it, is largely supportive care. I'm interested in supportive care for all patients with cancer, although given my clinical practice at the university, a lot of my work is specifically in breast cancer. I'm also narrow that often further to include patients with metastatic breast cancer. And so interested in sexual health in patients with breast cancer and also metastatic breast cancer, which is, I think, part of the reason I'm here today, but also looking at things involving, how a cancer diagnosis affects caregivers of patients with breast cancer, and other kind of quality of life impacts that cancer might have.
Mhm. So we said that this was going to be about sexual health. So let's shift to that topic. So sort of set the stage that you're both breast cancer experts, and breast cancer is clearly not the only cancer where sexual health issues play a role, but really it's a very common cancer, and it's one where sexual health, identity, all of that kind of comes into play. And unlike some cancers where you can make things better by sprinkling some estrogen on it, that's not usually an option that can be done in patients with breast cancer because of the role that estrogen plays in breast cancer. Maybe I'll start with you, Nicole. How did you recognize that this was a part of survivorship, a part of taking care of patients with breast cancer that needed more attention?
I think that it became apparent to me as I was a faculty member starting clinic when it was not something that was routinely brought up by patients. I think some patients felt very comfortable when I would talk to them about side effects, bringing up their sexual health, but more often I felt like I would specifically, if I didn't specifically ask, is your anti-estrogen therapy causing vaginal dryness? Is it impacting your sexual desire or sexual health? It wasn't necessarily always brought up. And so that made me think, well, gosh, how many patients are maybe thinking this is normal or thinking there are no options for treatment or aren't comfortable bringing this up to their provider? And that's what I think emphasized to me how important it was to make it a goal that everybody talks about sexual health as part of their cancer care.
Right, because there's almost like this conspiracy of complicity where the patient thinks, well, the doctor didn't ask me about it, and then the doctor is thinking, well, the patient didn't bring it up, and since talking about sexual health can be uncomfortable, and I would say definitely my generation, probably there was no emphasis on it, and I grew up in a time where 95% of medical students were male, and the idea of talking to a breast cancer patient about sexual health was not something we had experience with. So the traditional person in my generation wouldn't ask, and if the patient brought it up, we'd talk about it, and the patient's thinking, well, I'm not going to bring it up because he didn't bring it up, and so it just didn't get discussed. So I think it's a different generation, and obviously also over 50% of physicians are female, which is really also contributing, I think, to this greater understanding of talking to women about issues that are important. So I applaud you for that. Sneha, anything else you want to say about kind of your path toward wanting to be more open upfront and help patients with sexual health issues?
I think, I graduated fellowship about 10 years ago now, and even 10 years ago, I don't think this was something that we really talked about or wasn't something that was taught in fellowship or, even in, it wasn't talked about at our national meetings. So this is something that I've seen, nationally, has also kind of gotten more attention in the last maybe 5 to 7 years. And I will say that I think patients are a big part of this. They were really the ones to say, like, we need to start talking about this, and bringing it up to our providers. And so I think that it's been both providers have recognized that this is an issue, but I think patients have also become more vocal about, making sure that their quality of life is attended to in addition to treating the cancer.
And so, Sneha, we'll stay with you for a bit. Maybe talk a bit about the sexual health issues that you see in taking care of breast cancer
Mhm.
patients, and give a little bit of the physiology of what might lead to that,
Yeah.
but then also talk about how you personally bring that up in the conversation. Is it
Hmm.
part of a questionnaire that you have patients fill out before they show up? Is it something that you just, as you tick off the different um, organ systems that you want to talk about, how do you approach it? But maybe give us a little bit of a primer about sexual
Yeah.
health as it's related to breast cancer.
So I think, as a medical oncologist, I prescribe anti-estrogen therapies, so things like tamoxifen or aromatase inhibitors. And in young breast cancer patients early, and all of these medications can cause genitourinary side effects. So things like vaginal dryness, vulvar dryness and sensitivity, decreased libido, pain with intercourse. It can, even things like recurrent urinary tract infections, become more common in menopause and then when you start anti-estrogen therapy. And so I think all of these need to be recognized as potential side effects and discussed with the patient so that they know that um, these are not unexpected side effects, and these are things that we have treatments to help them with. These are not things that they just have to deal with. We actually do have good non-hormonal things, and in some cases, potentially some hormonal options to help them deal with these side effects. So those are some of the common ones, but I think some of the other ones that maybe we don't think about as often are the fact that some patients have issues with sort of body dysmorphia, or after a mastectomy maybe they don't feel sexual, they don't want to be naked in front of their partner, or that causes some discomfort. So there's a physical aspect of it, but there's also a psychological and mental aspect of sexual desire, and I think that we also need to address that part of it as well.
Yeah. Dr. Fleege, anything else you want to add to that in terms of the symptoms that you see and some of the other aspects of life that enter into discussions about sexual health?
Yeah, I think in addition, I think one of the other things is in breast cancer, we, not always, but can use chemotherapy. And for women who have not been through menopause, there's always the potential that use of that chemotherapy can put them into early menopause. And so I think that can, even patients who don't necessarily have a breast cancer that is driven by estrogen, can still have some of the anti-estrogen side effects if they receive chemotherapy and their ovaries are impacted. And so it really can broadly impact patients with a breast cancer diagnosis and treatment. I think Sneha did a lovely job talking about all of the side effects we think about. I think another one is like nipple sensitivity can be impacted as well. And then lymphedema is something we've also heard about following, surgery on the lymph nodes and subsequent arm swelling that can impact, sexual health, and not usually something that we would think about.
Mm-hmm. And then there's the psychosocial distress. I mean, especially women that are facing, I think anyone facing a cancer diagnosis, even if it is a ductal carcinoma in situ, feels when they're told they have cancer, feels that the stress of that, but especially women with significant cancer requiring chemotherapy, the whole idea of I'm mortal. How long am I going to live?
Mm.
And the psychosocial distress that comes with facing a cancer diagnosis in and of itself can be much sort of an anti-aphrodisiac, if you will.
Yeah.
Mhm.
And I think similar to part of my research with caregiver impact is that in romantic relationships, I think a breast cancer diagnosis can also impact a romantic partner, and that can impact sexual health as well.
Mm-hmm. Maybe let's talk a little bit about your research. So, part of your research, Nicole, is with looking at sexual health. And so, as a researcher, how do you approach what you're going to research? Obviously, you need to do the background and who's done what research because you don't want to just repeat things. So, you do a bit of a background, what if research has been done regarding sexual health in breast cancer survivors? And then how do you come up with a hypothesis and go about learning more? So what is your research, and maybe just there's a whole bunch of questions there. I'll let you talk.
Yes, I would say my research always starts with the patient. Like, I swear the best questions come from talking with patients in my clinic. And then also talking with Sneha. So what I'll say is that Sneha and I collaborate on almost all of our projects. We're both very passionate about quality of life research, improving quality of life for patients with breast cancer. The next step is, once I think I have a original idea, I see if it's been done, and probably 75% of the time it's already been studied by someone else. And then in the times when it hasn't, I think the hypothesis comes from asking the question. When I'm asking a question, I generally have an idea of what my hypothesis is, whether it's a project I'm doing in sexual health versus something in the caregiver space versus, advanced directives. I generally have what I think is going to happen. But the most important thing that Sneha and I do is we take our questions and our hypotheses to patients that have breast cancer. So one of my favorite things that we've started doing in the last few years is meeting with advocacy groups to talk about our studies before we go ahead with them to get their perspectives.
Okay. And put this to both of you, maybe talk about a study that you're actively collecting information on. And for those who don't know, how do you approach patients to be part of a study?
Nicole, do you want to talk about our study maybe with Aaron, or?
Yeah, either way. So we have a lot of, we just can't decide because we have so many studies. I don't know how much time you have. I would say one of the studies that we're incredibly excited about right now is a study in partnership with Aaron Sullivan Wagner, who founded After Cancer, which is another amazing organization. And one of her biggest goals, I think, has been empowering patients and survivors to talk about their sexual health, even before treatment started, so they know what to expect. And so through knowing Aaron and talking about maybe where we're missing opportunities, we realized that there didn't seem to be a lot of resources specifically for patients with metastatic breast cancer. And so, when we say survivor, that includes patients with stage 4 breast cancer, anybody living with a cancer diagnosis. But I think sometimes they're left out of the studies looking at things like sexual health. And so together with After Cancer, we are developing a sexual health course specifically for patients with stage 4 disease with the goal of improving sexual health. Right now, we are actively recruiting patients who are interested in talking about their experiences, how a stage 4 breast cancer diagnosis has impacted their sexual health before we build that course. We want to hear directly from patients. What are the things that we think we know what to think about, but what are we missing? What else should we be thinking about? And so if anybody is interested in being part of those focus groups, you are more than welcome to send me an email, and we'd love to talk more about that study.
Right. And so that you're looking for women who have stage 4 breast cancer.
Correct. And they don't, I think are willing to discuss the impact on their sexual health in a small group. Right. And it's virtual, so it can be done from anywhere.
Right. What would you anticipate the amount of, how long will you spend collecting this information? And then if I hear you correctly, this information will inform your developing information that you would then give to stage 4 patients in the future that would help them on their journey.
Yeah. So we are hoping to recruit patients through the next month to hopefully have these conversations. And then the course, so it'll be an online course that's self-paced, is the idea that patients can do different modules that are applicable to them kind of on their own time. And that would be developed over the next several months, ideally the fall timeframe. And our goal, which sometimes is ambitious, but our goal that we'll stick with right now, is that we'd like to enroll patients into a clinical trial looking at if that course is acceptable to them. Is it helpful? Is it usable? That feedback. And if it is, then, distributing it on a larger scale if it's actually helpful to patients with stage 4 breast cancer.
And if any women with stage 4 breast cancer want to participate in the small focus groups, how would they reach you?
So they can send me an email directly. There's additional paperwork that would have to be done to see whether or not they're eligible. But my email is my name, and I don't know if there's somewhere else that we could include it, but just Nicole-Fleege@uiowa.edu.
Okay, so we've got your name up there on the screen that people can see. So Nicole, if you could put that back up there, George. So the format for your email address is Nicole.Fleege
Dash
at
Fleege.
I'm sorry, go ahead. It's
Nicole and then it's a dash Fleege@uiowa.edu.
Okay, great. And we'll get that written down and put that up on the screen. So if any woman with stage 4 breast cancer that wants to be part of a small focus group talking about sexual health, that would be how you would reach out to Dr. Fleege, and they would get back to you and see if you're eligible to be part of that. Great. Thank you very much. And Sneha, maybe another study that you and Dr. Fleege are doing that I'd invite you to highlight.
So we're also working on our own survey study, which will actually not include just breast cancer patients. We're including patients who have stage 4 cancer of other types, such as colorectal and prostate cancer, because we are breast oncologists, and we know that there are needs that we're not attending to in terms of how we can help patients with metastatic breast cancer. But there are unique issues depending on the type of cancer that someone has that might affect their sexual health. And so we're trying to look at other cancer types, patients with stage 4 colorectal cancer and prostate cancer, for example, to see what are the issues specific to those types of patients, and how can we help them, with those unique needs.
Right. So you mentioned prostate cancer, and obviously there's sort of a parallel with breast cancer in that the breast cancer is often treated with anti-estrogens, and prostate cancer is often treated with anti-testosterone. Another field, and actually give a shout out to, you mentioned Erin Sullivan Wagner. She was a recipient of an Above and Beyond Cancer Award several years ago, and so I'm not going to tell you anything that she hasn't already told you, but she went through a cancer that included pelvic radiation, and that has all sorts of other specific issues as it's related to sexual health. And, her story was that she just didn't have a clue that these were going to be side effects, and has used her own experience and the wisdom she gained to not just help herself, but to help others. So in addition to breast and prostate, where there's medicines that often affect sexual function, the pelvic cancers that include gynecologic cancer, and bowel cancer, rectal, anal, colon, often the side effects of radiation can have significant impact. Are you trying to, in the study you're referring to now, broadly include those types of cancers as well?
I think we're sticking with prostate, colorectal, and Nicole can remind me, I think we're also including patients with ovarian cancer. And the hope is that we could expand this to include patients with any stage 4 diagnosis. We're going to stick to those for now and see what kind of data we can glean. And then, I think the goal would be that we would open it up to a broader base of patients to get even more data. But I did want to go back. You had asked me how I bring this up to patients, and I never answered your question. And then we started talking about Erin, and she talks about this all the time because that's a big part of her organization, is teaching providers how to bring this up with patients. And so, a lot of the courses on her website and her organization are actually directed at providers, because this is an uncomfortable thing for some people to bring up. And so you can go to her website and you can actually get information if you are a provider on how to bring this up with patients. But I think for me, I've become so used to asking these questions that it is sort of like a normal thing that I ask, and I bring it up when I prescribe anti-estrogen therapy. I say these are things that might happen, so if you're experiencing these things, please let me know. And we're very lucky that we have a gynecology program here that's very supportive, and we can refer our patients to them to help us with some of these issues, because some of these patients need a pelvic exam to figure out what's going on. And they need to see, is it vaginal dryness from their anti-estrogen therapy, or is something else going on that needs to be treated? So it's really important, I think, to partner with gynecologists and, for male sexual health with urologists, to make sure that the diagnosis of what's going on is actually correct.
Yeah, that's a really good point, and I would say the same at my survivorship clinic. I don't have the gynecologic or urologic experience. I can help identify the problems, but fortunately, I have a wonderful gynecologist who is a partner. So when I identify female sexual health issues, then she takes it from there. And the same in terms of male sexual issues. I've got a urologist who really is very good at that as well. So yeah, it's a team sport, cancer and cancer survivorship. Often, those of us who see the survivors, one of the primary things we do is to recognize problems. We may not be the ones that solve the problems, but the first step is to recognize them. Yes. I would ask each of you to comment on, so I would imagine that many times the patients come by themselves. Occasionally, especially when you get to stage 4, it might be more common that the spouse or sexual partner would be in the room as well. Does that happen often? And what's the conversation? Is it different when both partners are in the room? How would you address? So assuming we're talking about sexual health with two people, not that it has to be that way, but there's two people involved, two different psychologies, two different individuals, and how do you address the couple aspect?
That's a really good question. I think that I do not like having someone else in the room does not stop me from asking the question. I try to treat asking about sexual health the same way I ask about like joint pain, right? It should be a normal part of our question. So I try to remove the taboo portion of asking about sexual health. But, I think what's so great about and interesting about your question is, despite the fact that I do a lot of caregiver research, I don't look to the person with them and ask them their experience. Any of my questions related to sexual health are related to the patient. And so I would say that when a sexual partner is with them, they may offer things up, but if they don't, then I don't routinely engage them for their perspective.
Sneha?
Question. I actually think it might be more uncomfortable when it's like a friend or the mom, or where it's like, I don't know if that is a comfortable thing to bring up in front of the person. When I know it's the spouse, I think I'm probably more comfortable, because it's maybe something that they've even talked about between the two of them. But sometimes when it's someone else, I don't know what the comfort level of the patient will be to discuss that in front of that person. But I think it's still an important thing to talk about. So one thing that we're starting to do here is that hopefully in the next couple of months, that patients will get a questionnaire when they come, and they should get that twice a year, whether they're seeing us in the medical oncology clinic or like a breast surgeon. They'll be prompted to fill out a sexual health questionnaire. So if for some reason they're not very comfortable talking about it, and because of the nature of the topic or the person in the room with them, they can still say that they are having these issues, and sort of flag that, so that we can bring it up, or at least make appropriate referrals based on what symptoms they're having.
Okay. So one gap that we have or at least I have not identified a resource, is sex therapists. So we have a gynecologist that help with female sexual health and urologists. I'm aware of the profession of sex therapists that work with couples. I guess my question is, at the University of Iowa, do you have that resource either within the university or within the community? And have you had experience with referring patients to those therapists that identify themselves as sex therapists?
I don't think we have sex therapy specifically at the university. We have therapists, and many of them can counsel couples, but I don't think we have anyone that's specifically a sex therapist. There have been a few times where that has come up as something that, like when after the patient saw one of our gynecologists, that came up that they thought that would be helpful. And so we did community referrals for those. And actually, I didn't know where to find a sex therapist for my patient. So I emailed Erin Sullivan Wagner and I said, hey, how do I find a sex therapist? And she gave me a great website that you can go on, and you can just say what area you are in, and it will give you a whole list of sex therapists or whatever area the patient's in. So that is how I have found referrals for my patients in the past.
Okay. Nicole, any experience with connecting patients to sex therapists?
Yes, I would echo what Sneha said. I'm also not aware of any sex therapists within the university system. I've been able to refer to the community, and I've identified that, you know, those specific sex therapists with the assistance of like social work here, and some of the therapists that work at the university. I'm gonna have to think about Erin now, though. One thing I was looking at is there's an app called the Rosie app that is around sexual health and was developed by a gynecologist. And so I was trying to see quickly if they had a list of sex therapists as part of that app. I'm not sure, but there's also, I think, probably resources to find there.
Okay. Before we open it up, because I do want to open up for questions, because I do want to leave time for questions. Any particular aspect of this topic that I haven't asked you that you would like to talk about before we go to questions? And I'll start with you first, Dr. Fleege.
Oof, I was hoping to go second. I had to answer the high school question first, so I would like to have Sneha go first.
Okay, Dr. Phardke, as the senior
Sure.
oncologist in the panel, you get to go first.
So I think, you know, and it's going to be too big of, this could be a whole topic in and of itself, but one of the things that comes up frequently is the use of hormones for these patients. And I think it's so individual, and it depends on the individual patient and the type of breast cancer they have. And if they have, you know, genetic mutations that would increase their risk of a future breast cancer. And then we can talk, there's local estrogen options versus, you know, systemic hormone options. So like I said, that could be a whole topic in and of itself, but that comes up frequently. I mean, patients have a lot of questions about hormone therapy. And so again, I think that's where partnering with between the oncologist and, you know, a gynecologist, for example, can be really helpful. But I think, you know, one thing that I will stress is that we have reasonably good data now that, you know, local estrogen is probably safe for most patients with breast cancer. So
and local, just define local
yeah,
estrogen for those who might not know what that means.
Sorry, yeah. So vaginal estrogen, so like a cream or a suppository, you know, that can really help with a lot of the issues with like atrophy and dryness and painful intercourse. You know, we always say, you know, we try to use non-hormonal options if we can, but if it's a quality of life issue, if it's affecting the person's relationship, you know, I have patients who we have talked about the risks and benefits, and they've decided to use it, and it's really helped them. So I do think that these are nuanced conversations that really need to be individualized.
Yeah, I'm so glad you're bringing that up, because the easy answer could be no, never, under any circumstance, you know, and that doesn't really take into account this whole conversation about risks and benefits. And
Yeah.
and so I'm glad that there are situations in which the risks and benefits have been discussed, and you agree that the risk is relatively low and the benefits is great, and so it's not like a never
Right.
situation. Yeah.
Yeah.
Super. Okay, we're back to you, Dr. Fleege.
I think I'll piggyback off of what Dr. Phardke is saying, is that I just encourage patients to advocate for their sexual health. I think that there are a lot of treatment options, not just medication wise. We talked about non-hormonal options like lubricants and vaginal estrogen, but also things like pelvic floor therapy. And, you know, when you see a gynecologist, there's topical pain medicine or numbing medicine if they're having pain with sex. And so I think there are a lot of options that can't be offered unless we know that there's an issue. And I just want to say, I've mentioned it earlier, but I think it's important to think of sexual health as just as important as if a medication side effect is causing like elevated blood sugar, in that it can really impact quality of life. And while all of the goal of our treatment is to help patients live longer, I think it's really important to also help them live better. And so I think making sure people feel comfortable knowing that like we support that is an important side effect and can really impact you personally and in a relationship. There are options, and I just hope people, you know, are comfortable asking about them.
Great. So we're going to open up for questions now. So our live studio audience gets first. If you're watching us right now live streaming, you can put your question in the comments section of the software you're using right now, and we'll be monitoring those. But we'll go first to our studio audience. Here we go.
Yeah, I've just got a question having to do with sexual health in general. Could it possibly be that we're understating the significance of the importance of that, given how important sexuality is, you know, to the health and well-being of the individual as a whole? When it comes to cancer and recovery and survivorship, is it maybe much more important than even researchers think?
I think
Yes.
very possibly.
Yes.
Our part of, you know, doing the survey we're doing is to explore that, like what type of impact sexual, you know, their diagnosis has had on their sexual health and how that has impacted them as a whole. I find it really interesting. There was a study done that looked at exercise in patients with stage 4 breast cancer. And the primary thing they were looking at was how did fatigue improve and anxiety and depression, but they looked at sexual health, and they found that patients who did this exercise program actually improved their sexual health. So I think it does have so much more of a whole body impact than it's often given credit for.
Okay.
And I think it's very likely that we don't give enough, it's not given enough importance or a priority. And some of that is, I think, like Nicole said, there's somewhat still, I think it's a little bit taboo maybe to bring it up, or people are embarrassed, or I think I've heard from some patients like they feel like, why should that should be the focus. You know, I'm just grateful to be alive and to be here, and I shouldn't worry about that. So I think there's some hesitation probably on both providers and patients to bring it up. And I think that's, you know, we're trying to change that. But I think that that's something that, you know, Dr. Fleege and I are trying to teach to our fellows, that, you know, as they go out into practice, that this is something that is really important and shouldn't be something that's, you know, just brought up, you know, if a patient brings it up or something. It should be something that is a priority.
Okay. We have another question here.
Yeah, this is kind of outside of your scope of research, but when we're talking about the quality of life for cancer patients, I read recently that there has been some breakthrough on how to address fatigue with cancer patients. Have you aware of any of that, or haven't any discussions about that?
So fatigue, how do you address fatigue with your patients? And is there some new research about different ways of addressing fatigue?
I would say that exercise, one of the few things that has been proven over and over again, is that exercise improves cancer-related fatigue. It's one of the endpoints that can definitively improve with exercise. That is typically based on guidelines that recommend strength training 2 to 3 times a week, and then up to 150 minutes of aerobic exercise. If you're like me, that sounds incredibly overwhelming. And so what I like to point out is that, you know, gradually getting there. Even it's how you perceive moderate exercise to be, not a set definition, is what they mean. But that is my area of research. I'm looking at, that might sound newer to me. I don't know if Sneha is aware of other groundbreaking fatigue related.
So I don't know of any medication related new findings. I know in the past that, especially like in the sort of more of the palliative setting or in the metastatic setting, sometimes this is probably in the last few years, people have stopped doing this, but we used to use stimulants occasionally for cancer-related fatigue. But I think there was some new research that showed it really did not improve fatigue or quality of life, and there were some risks to using stimulants, and so that we really stopped doing that. But as far as I know, exercise is the only sort of data-driven way to improve fatigue. But I think when we talk about sexual health, it's not just the genitourinary side effects, right? If you're really tired, you probably aren't interested in having sex. So I think that a lot of these side effects or symptoms related to cancer and their treatment really go together. There's a lot of overlap between them.
Okay. And we have another question.
Yes. Do you, when you sit down with a patient who's got breast cancer, do you let them know upfront that cutting the muscles would make their chest numb, and plus radiation treatment?
So the role that surgery contributing to numbness, and in particular maybe nipple numbness, and also the effects of radiation on the breast, is that something that you think surgeons and radiation oncologists are forthcoming enough about those potential side effects?
So yeah, I think Nicole and I aren't surgeons, but I know that that's something that our surgeons here at the university bring up frequently. And it's one of the things that they discuss when making the decision between a lumpectomy and a mastectomy. There is data that a mastectomy can affect sensation and chest discomfort and range of, shoulder range of motion, that those things can be affected more after a mastectomy. And then there's some cases where a mastectomy cannot be avoided or should not be avoided. But, I think those are things that our surgeons definitely bring up as they're making decisions about the type of surgery. Radiation, I think, maybe I don't know if there's as much of a discussion. Maybe Dr. Deming, you can comment on that as a radiation.
I would say need for improvement about discussion, especially when it comes to late side effects. There's a lot of discussion about the acute side effects, which, are relatively short lasting and go away. But the idea of talking about 3-year, 5-year side effects of the fibrosis and is probably under discussed. Yeah.
I think the other thing to think about too is that we might say a sentence or two about it, but we're also telling patients 700 other things that could affect them, or we're talking about breast cancer outcomes. And I think that those visits can become incredibly information intense. And so what is really absorbed is probably not, someone can't in that setting absorb everything. And so one of the things I love about medical oncology is the frequency at which we see patients. I often get to talk about side effects at multiple visits, but I think my perception of what I've counseled someone on and what they really took in at that time is often different. And so I think we probably have to recognize that when it comes to what we've talked to patients about sexual health impacts.
Yeah, that's a really good point. And it's all, again, a reason for survivorship clinic, because understandably, when the patient's starting on their journey, they are most concerned about number 1, 2, and 3 is treating the cancer. And they're probably more likely to want to talk about the side effects as you have subsequent visits where the cancer control is done with. Or for stage 4, where it is a forever thing, you just develop this relationship that the relationship between a patient and a doctor, the more trusting and caring that relationship is, the more likely you're going to be able to comfortably get into these topics. So, well, this has been great. I think we're going to bring it to a close right now, but I just want to thank you both. It is incredible abundance of riches to have 2 leading breast medical oncologists from the University of Iowa on the show at the same time. So our guests tonight have been Dr. Sneha Phardke and Dr. Nicole Fleege, both breast medical oncologists at the University of Iowa, and we've been talking about sexual health as an important topic in cancer survivorship. So thank you both, and we'll have you back again some other time.
Yes, thanks
That
for
would be
having
great.
us.
Thank you.
You bet. If anyone watching this program right now thinks that this program would be beneficial to someone who's not watching it, good news, it will be available on demand for anyone to watch at the Above and Beyond Cancer YouTube channel or the Mercy Cancer Center website. I hope you'll all join us again next week. Thanks, everyone.